Hello and welcome to the Functionally Enlightened podcast with Dr. Sharon Surita. We interview well-respected medical and functional practitioners, as well as patients who have overcome disabling chronic conditions, such as dysautonomia, and reclaimed their health. These enlightened guests provide helpful tips on managing chronic pain and illnesses, using a combination of traditional and whole-body healing modalities. If you're interested in natural healing and quality of life improvement, you're in the right place. Thank you for listening to today's episode.
Welcome, everyone, to the Functionally Enlightened podcast, where we really dive into health topics that empower you to take control of your well-being. Today, we have the privilege of speaking with Dr. Tim Sayed, a double board-certified plastic surgeon, renowned for his expertise in breast implant illness and explant surgery. With over 1,000 successful procedures, Dr. Sayed has dedicated his practice really to helping patients navigate the complexities of implant-related health issues. And this topic is near and dear to my heart, as well as to a lot of our audience. So I'm really excited to have you here, Dr. Sayed.
Well, it's my pleasure. Thank you very much, Sharon. I appreciate the opportunity to converse with you and share some ideas with your listeners.
Absolutely. So, Dr. Sayed, what inspired you to specialize in breast implant illness and in this type of explant surgery?
Yeah, it's sort of very organically developed over the course of time. I mean, I've been in practice now. This is my 23rd year in practice, but I used to practice in a different market in South Florida, did a lot of, primary breast augmentation, got known for breast surgery, both cosmetic and reconstructive, a lot of cancer reconstruction, both using implants and autologous methods and, flaps and grafts and things. And I relocated to Southern California for an opportunity. And then when I set up this private practice, over time, I just had a few champions of patients who were strong advocates in the explant community. And in a way, they kind of forced me to do a deep dive into understanding a little bit better what's going on. There are a lot of things we don't understand, and I would just say that at the outset. But to try to, better inform myself as to some of the issues that the patients were grappling with. What are some of their, now that when I lecture about BII and explant surgery at plastic surgery meetings, I tell my colleagues they need to know their memes. They need to understand what are the kind of big thematic issues that patients deal with who are considering explant surgery in this patient population. And then I just learned from my patients' experiences, started to really see a lot of salient health benefits that a lot of patients were sharing. We also, had to kind of go on this journey with them because there are a lot of implications here, both functionally, which I know you want to talk about in functional medicine, but aesthetically, and what it means to believe in yourself, to feel beautiful, to feel sexy, to feel, powerful in one's femininity as a woman. I think all these things are very wrapped up together. And I think you have to have a certain amount of compassion, and also you have to think a bit differently in working with this patient community than, say, patients just coming in for first-time breast augmentation or coming in for liposuction or something like that.
Mm-hmm, mm-hmm. So let's take it back a little bit and talk about what exactly is breast implant illness and what are some of the symptoms that people might be presenting with.
So BII, or breast implant illness, is a fairly poorly understood phenomenon that essentially represents a set or a cluster of inflammatory systemic symptoms that some patients who have breast implants develop that they didn't have before they had breast implants. And it's a very controversial subject because, I say that it's kind of like religion and politics, it's got its like, atheists on one end and it's fundamentalists on the other end. And then there's a lot of people in the middle who are trying to kind of sift through, what they believe the truth to be. And on the one hand, there are people who think that all implants, silicone-based, implant shells filled with either silicone or filled with saline are inherently toxic and that they shouldn't be implanted into people. And then at the other extreme are a number of medical colleagues, a lot of plastic surgeons who say, yes, these patients who experience these symptoms may experience improvements when their implants are removed and not replaced with new ones, but couldn't that be a placebo effect? Couldn't it be some kind of manifestation, somatization disorder? anxiety, social media driven. Some will go so far as to call it a cult and a hoax. You know, and I don't think the truth is at either extreme. I think that this is a phenomenon where some patients' bodies, when you put a foreign object in that is made of materials that don't naturally exist in that concentration in the human body, some patients' bodies are going to react to that with an immune response, an inflammatory response, and that may be able to be suppressed for a long time. And perhaps over accumulated exposure, in some people, it exceeds a threshold and then it manifests with systemic inflammatory symptoms. And people are trying to look at understanding the basic physiology of this and what the triggers might be. And it's still, elusive in some ways, but that's basically what BII is. And I
Mhm.
don't think it affects every woman who has breast implants. I don't think the
Right.
data supports that. But I also don't think this is just a placebo effect being achieved in so many of these women. If you look at the statistical data on what patients report in terms of their symptom experience, and I'll talk about the specific symptoms in a minute, over 90% of patients who would self-identify as having breast implant illness or being significantly concerned about that as a reason or a possible explanation for symptoms that are really impairing their quality of life. Over 90% of those patients, according to the published plastic surgery literature, will report improvements in at least several of their symptoms if you poll them at like 6 months or a year postoperatively. And there have been publications in peer-reviewed plastic surgery journals discussing that. Again, the
Yeah.
skeptics will say, well, if you believe it strongly enough, you're going to believe you're better, and mind over matter, and the mind and body are connected anyway. And to some extent, you could say, well, then does it matter if it's a placebo effect or not, if they're experiencing a benefit? But then the flip side of that is to say there is some science around, what could be going on here in terms of foreign body induced inflammatory reactions. In terms
Mhm.
of the symptoms that patients typically encounter and what things tend to get better the most according to patient reported outcomes, it's the following: joint pain, fatigue, brain fog, hair loss, rashes, dry eye and vision problems, food intolerances, reflux, palpitations, anxiety, depression, uh, swelling, numbness in the digits, burning in the chest wall. Now, there are other symptoms that and those are the things that tend to get better the most if you look at the data. There are the other symptoms. The list is very long. The
Mhm.
list is so long that, part of the controversy is like, I have some of these symptoms, right? I don't have breast implants. I'm not female. But I have neck pain and joint pain sometimes. I have fatigue sometimes, I get a rash every now and then. But, I think the difference is, yes, people can get symptoms. And if you have a very long laundry list, then, how are you really being selective to say that this is associated with this? But on the other hand, I also think that most patients, especially women, are very intuitive about their bodies and can understand if something is not like it should be, or is probably, I wish it wasn't this way, but I can understand why it is. So I'll give you an example. Like when I operate, I do several explants a week. And if I do a couple in a day, then at the end of the day, I have neck pain and I have, shoulder pain and I'm fatigued and I'm kind of tired and maybe hangry, but I have a reason for that. I understand that, by doing surgery, my neck posture over the 20 some years of doing this is not what it would have been if I had been in a different profession where I didn't have to look down and lean forward all the time.
Mhm.
So for me to have neck pain every now and then has a very easily explainable source. And while I wish I didn't have it, I understand why I do, and I do the things I can to mitigate that. Right.
Mhm.
And I think there's a difference for women, to say, yeah, I'm postmenopausal and I have hot flashes and I have fatigue and maybe I have irritability emotionally because my hormone levels are not what they're not at homeostasis. They're not what they were, when I was premenopausal, and maybe I'm not optimized on hormone replacement and, bioidenticals and things to try to make my levels, within a sweet spot. But I understand why that is, and I try to navigate that, as opposed to I'm 35, don't have that stressful a life, and yet I feel like I'm 70 because I can't get up in the morning. Well, that's a patient saying there's something wrong with my body. It's not doing what it should be doing. And I think we should believe these patients, I think we should believe that they understand that there's something that's not as it should be.
hmm And it's very similar in the mesh implant illness world. All of the
Mhm.
symptoms you named are the ones that I'm seeing in my clients as well as
Mhm.
what I've experienced myself. So
Really?
I know with that, there are some instances where a client or a patient of, I'm not sure about your patients, but where they might exhibit some of these symptoms pretty instantaneously, but
Mhm.
usually not. Do you see
Right.
that in your practice? Does it generally
Yes.
take time?
Good point. So, yeah, I mean, if you look at the data on some of the published literature, it says that initial onset of symptoms is sometimes 7 to 10 years after, augmentation. There are some patients that I've seen where they feel like they knew within a month or two that something was wrong. And some patients, similarly, after they're explanted, will experience improvements within the first several weeks, within 30 days. Not necessarily everything that's going to get better being at its best, but noticing changes. I mean, I've had patients who say that the next day they can already tell something's better in their body. I tell them maybe that's Percocet and, anesthesia talking, you need to give it a little bit of time. But on the other hand, these patients typically will have improvements that are sustained if you poll them at a year and their, fatigue level is night and day change. They now, like their family members are saying that they are back to the person they know and
Mm-hmm.
they were living with a zombie. There's something real that's happening there. And my theory on that, and again, there are a lot of theories to try to explain what's going on. Nobody's really figured out exactly what's happening here. But my theory is that you have an exposure and our bodies have various factors that influence our wellness and health and our illness status. And so one of those things is our genes. And you're
Mm-hmm.
not able to select your genes, they're selected for you by parentage. And you get half of your genes from your mom and half from your dad, um, and you don't get to pick that. And if you have a sibling, they also have half from each, but not the exact same half, right? So unless they're an identical twin. So with that, you are set up for certain things that you may not be able to alter about your susceptibilities. But then even identical twins who are genetically identical over time, they don't look exactly the same. They don't like all the same foods. They're not identical human beings because they get exposed to different things and then their immune systems interact with different things and little micro mutations and micro inflammatory changes to the expression of genes and the proteins and the things that they express will change. And then depending on what they eat and what they put on their skin and the environment they live in, then the microbes that they live around, the microbiome is going to be different.
Right.
So you have your genome, your microbiome, and then you have what's now being called the exposome, which are the things you're exposed to. And if you live in Los Angeles, you're going to be exposed to worse air than if you live in the mountains in Colorado, just by pollutants in the air. And if you use certain deodorants with aluminum, you might be exposing yourself to certain chemicals that you wouldn't be if you buy Whole Foods, organic deodorants. They may not work as well as antiperspirants, but they, might serve a decent job as a deodorant.
Mm-hmm.
Um, if you eat organic, clean foods that don't have a lot of preservatives and additives, you are setting your gut health up better than if you're eating highly processed, sugar laden, processed flours, dyes, all chemical preservatives. And we see this, and we see that when people go on vacation to other countries that have cleaner food supplies, that they often, even if they have irritable bowel syndrome, they find themselves able to eat pasta with no issue. Whereas they come back home and they're like, I thought I was gluten sensitive. I thought I couldn't eat any pasta because every time I eat it in the US, I have GI upset. Well, it's maybe not the gluten by itself or the pasta by itself and the starch, but it may be how it's processed and so on.
Mm-hmm.
So with implants, I'm just a little bit more long-winded, but basically with implants, my theory is that here you have an exposure that you can't, unlike gluten in pasta or aluminum in your deodorant or smog in the air, you can't take a holiday from it very easily. I can decide I don't want to eat gluten for 6 months and see if my body feels better. I can decide if I only want to buy organic fruit and vegetables and see if my body feels better. I can decide if I don't want to, wear a certain deodorant or put certain skin creams on my body and see if my skin is happier. But with explant surgery, you have to take out this object, or objects, with an operation. And it's an invasive thing, and it costs money to do that and takes recovery, takes time out of your life. So it's a big decision. It's a bigger decision than just trying to not eat gluten for 6 months.
Mm-hmm. That's
So I think some
precisely
people
right.
develop an acquired intolerance over time to a repeated exposure where it's there all the time, unlike gluten, where it's every now and then you're getting a gluten spike. This is like it's always there. And if it's at a low level and your body keeps suppressing the inflammation and kind of tamping it down, and at some point it just breaks through and the body waves a white flag and says, I can't
Hmm.
take something off my plate here, literally or figuratively. I need to, reduce my inflammation because there's triggers here that I just can't get rid of.
That's exactly what we talk about when we want to look at the low-hanging fruit. So, of
Mhm.
course, the surgery is some people already know coming in, I have to get an explant, but most often you want to tackle, like you said, the food, the air
Right.
quality, the water quality, and you want to bring down that toxin bucket overload. So
Yes.
with the genetic predisposition, we know that there are some genetic SNPs that might make it harder for people to detoxify
Yeah.
or for, nutrient assimilation, and all of these things impact how we go through our day-to-day lives.
Yes.
So I know as people are coming, there are many people that are fully aware that breast implant illness, mesh implant illness, and other implants, even the dental implants, we talk about that often, they
Mm.
can cause problems. As you mentioned, it's not everyone, and actually it's probably a small percentage of people
Right.
compared to those who receive the surgeries.
Yes.
However, it is still related to that toxin bucket overload, whether it happens right at the point of surgery. But
Mm.
considering all the things that are happening with your exposures during surgery, I mean, the anesthesia, you have pharmaceuticals that you're taking before, during, and after.
Right.
Most people are probably not on a 100% organic diet
Right.
where whole foods, no processed foods,
Yeah.
we want to be sugar-free, grain-free in most cases, because when
Yeah.
we have these autoimmune-like conditions, we know that grains are probably going to exacerbate the
Mhm.
symptoms. So
Yeah.
going back to, we have a client or a patient who's exhibiting some of these symptoms. How do you approach diagnosing breast implant illness or BII, given that you have so many challenges in identifying that condition?
Well, usually by the time the patients have come to us, they've actually done a pretty deep dive on some of this already. So they've often been to functional medicine doctors. And if they haven't, I encourage them to do so, naturopaths as well. But functional medicine, I think has a good balance of some of the traditional norms of Western, we'll call it medicine, and some of the more holistic areas that have often been associated with sort of Eastern medicine that traditional allopathic doctors often sort of poo-poo, but really, I mean, if you think about it, we're all made of the same space dust. We're all, made of the same atoms and molecules and ions that everything else on planet Earth and the rest of the universe are made of. And a lot of medications that are beneficial to the human body and minerals and herbs and things like that. I mean, they come from nature. And now we're synthesizing a lot of things too over time as people learned chemistry. But at the end of foxglove, digitalis is good for the heart. If you have an arrhythmia, that comes from, a plant. Atropine, which if you have a slow heart rate, it can be life-saving medication is derived from belladonna mushrooms. You know, why do we have a certain amount of requirement for things like magnesium and calcium and phosphorus and other minerals that are made of the same minerals that you can find in rocks, because we are of the same substance. And so I think it's important for patients to explore diagnostic explanations for their symptoms with testing and see appropriately qualified non-surgical specialists. I think they should consult with nutritionists or at least be given nutritional guidance because if you're eating super highly inflammatory food, you're not going to be optimizing your inflammatory health no matter what you do. And similarly, I think people should explore the air quality in their homes, the water quality, what kind of water they drink. Are they drinking out of plastic processed bottles?
Mhm.
Are they is this Kangen water? Is it, pH balanced? Is it extra hydrogenated water? I mean, I have, colleagues who very strongly feel that only certain types of water should be consumed. And are they getting enough water, no matter what their water source is? All of these things. But, I think patients should get testing, maybe see an endocrinologist, rheumatologist, depending on what their symptoms are, to exclude uh, certain diagnoses that have diagnostic thresholds of levels like lupus and rheumatoid arthritis and other autoimmune conditions because they may rise to a threshold where if you're given that diagnosis, there may be medical treatments or surgical treatments, but there, other ways to treat them, and you don't want to just assume that it's the implants. I think that's a diagnosis of exclusion. And part of the problem here and the challenge is that BII is sort of like fibromyalgia. It's a term that's now being used in some circles as a label and a pejorative label, basically to say, here's one of these ladies, she's got all these symptoms. We don't know what's going on with her. We're going to test her. Her levels aren't going to be high enough to call it anything. What do we tell her? She wants a name to this. But if you look under the hood, at what some of these patients' lab tests look like, many patients have had abnormal levels of ANA, rheumatoid factor, C-reactive protein, ESR, other things that are markers of inflammation, but unfortunately, they're very non-specific. They don't tell you what the source is. They just tell you there's inflammation. And because if the level of ANA isn't high enough to meet a threshold for calling it lupus, then most doctors aren't going to put you on, and nor should they necessarily, put you on disease-modifying anti-rheumatic drugs that are, or DMARDs for short, that are designed to that are FDA indicated, for example, for treatment of those conditions, especially if they can be very expensive biologic medications. And for your insurance to cover it, you're going to need to have, strict criteria met, right? But so a lot of these patients are kind of like, well, I had some levels. They told me it might be kind of lupus or low level of it, but then I got it tested again another time and it was normal, and I don't know what to do with this. So I think it's important for patients try to exclude things, to have their thyroids evaluated, for hypothyroidism and Hashimoto's and things like that. And then to some extent today, because of the current status, we don't have a specific biomarker to test for BII. There is some interesting research. There was a recent paper published on, I think it's fibroblast growth factor 19 levels that after explantation, these levels had changed significantly. And it's such that if the levels are too low or they're too high, they can be implicated in things like liver dysfunction, fatty liver disease, diabetes, glucose control in diabetics, and basically sort of inflammatory cascades. And that having, this FGF19 level being within a reasonable sweet spot of levels, which is the case for most biomarkers and electrolytes and other things, is that if it's too high, it's not good, and if it's too low, it's not good. It's not such a thing that, like, there's no such thing as too high a level of some nutrient. Well, sodium, if you have hypernatremia and your sodium level is too high because maybe your water level is too low, or if your pituitary gland is doing weird things, it can be life-threatening, right? You need to have a certain amount of sodium for cells and function of your body, but too high level or too low a level are both dangerous. And so we may eventually learn a biomarker that we can test people for before we put implants in them or before we take them out, to say, you know what, you're at risk. You're at a higher risk than others. Some people believe MTHFR status as part of their methylation pathway can play a role in susceptibility, but we don't have a specific thing where we can say, okay, if you're heterozygous for this particular gene variant, that you are going to 100% get BII if you have implants put in you, or you are 90% or 70% likely. We don't have that today. And so I have to tell my patients that basically, if you do an explant, you have to think of this as much as a diagnostic procedure as a hopefully therapeutic one. In that, if you get therapeutic benefit from it, then we can say that it essentially diagnosed you with BII. And there's a little bit of the tail wagging the dog concern there of like, well, can you just sell this operation then to anybody who has any of these symptoms? And so that brings me to the other part of it, which is like, no, you don't want to just sell people a promise because we don't know how to test for it today in a predictive way. Well, all we can really say today is, if you look at clinical outcomes, the outcomes are very favorable, particularly the worse your symptomatology is. The more of these issues you have and the more like quality of life altering they are, the more those patients report improvements when you assess them. And most of these are patient-reported outcomes, which there's a certain subjectivity to that. But at the end of the day, this is about quality of life. Quality of life is part of health. And, you know, when you put breast implants in somebody, you're not saving lives. You are arguably providing something that they perceive as a quality of life benefit. And if not enough people felt that it was benefiting their health, then you would ask yourselves, what am I doing? You're putting objects into people, why are we doing this? And then by the same token, you could say, if I'm taking these out of patients and in many cases, not necessarily improving and maybe worsening the aesthetics, because that's why they put the implants in the first place, am I helping these patients? And if I didn't have data from my patients and from the literature that says, yes, we are helping overwhelmingly the majority of these patients, you'd ask yourself, am I doing harm or am I doing good? And I believe we're doing a great amount of good for these patients.
Yeah, I love that you put the resources out there, Dr. Sayed, for people to have informed consent and really know, this may or may not solve some of your problems. And I'm
Right.
sure that they understand it may not solve 100%, but
Right.
just considering the materials, they're supposedly inert, but as you mentioned, we have that predisposition. And what I've been studying is biofilm colonization and how you have other microbial communities kind of organizing on implant surfaces.
Right.
So I know there are some surgeons who are sending the
Yes.
explant or some type of tissue sample to have, I guess,
Yeah.
bacterial
Testing.
testing, yeah,
Yeah.
pathology.
So yeah, we do that we make it elective for our patients to choose if they want to do it. And part of the reason for that is, again, this informed consent and agency of power. In a way, what really jazzes me about doing explant surgery, because it's very different in some ways. I mean, we still think about aesthetics and we still have to have very lengthy discussions about aesthetics. And there are some patients where the aesthetics are improved by explanting them and maybe doing a breast lift, sometimes doing fat transfer. But there's a certain amount of this kind of empowerment that just comes from letting people own what is their nature and not being afraid of their nature and not being embarrassed about their nature. I mean, like, I have a daughter and I don't want her growing up thinking that if she has a certain breast cup size or her nose has a bit of a bump or something, that she's not beautiful. I mean, to me, she's perfect, right? And so the idea that we should tell particularly young women and teenage girls that they're less than unless they have, and this has been going on forever. The media have been different. I mean, there are cave paintings of people with jewelry, and if you go to the Valley of the Kings and Queens in Egypt, where I'm originally from, you will see hieroglyphics and you will actually see in the museums, you can see examples of jewelry and makeup from thousands of years ago. So we've been adorning ourselves for the longest time, and we're visual creatures. And it plays a role in mating and sexuality, not just for humans. Peacocks strut their plumage, and different animals have different mating rituals that have visual aspects. So it's part of being a human being and being an animal, and being part of the universe. And we don't have to pretend that it's not. If it weren't, we wouldn't have a plastic surgery industry in the first place, right? So it'd be hypocritical to criticize patients for why they put implants in if they chose to get implants. But what this does allow us to do is to help people maybe get out of their own way of self love and self-esteem, self-empowerment, and say, you are enough as you are. And if somebody makes you feel like you aren't, then that's about them. It's not about you. And you should maybe reevaluate the nature of the relationships that you allow yourself to be in, rather than necessarily judge that you're not beautiful or sexy because you have A-cup breasts, or because one is bigger than the other, or one is more saggy than the other, or you have tuberous breasts, or any of these other variants. I don't call them deformities; they're variants of human development. So at the end of the day, there's a lot of this empowerment, and I think that it would be nice if we could have better bio markers and testing that we could, risk stratify people, but really this informed consent give people the power to make choices with information, so they can choose if they want to accept risks associated with implants, knowing that statistically there's probably a very good chance that they're not going to have any of these issues. And there's certainly some people who would have had some of these issues even if they never had breast implants put in. They're going to be people who are going to have autoimmune conditions genetically or just sporadically. They're going to be people who will have fatigue and anxiety and palpitations and brain fog and reflux and all these things, even if they never had breast implants put in. But, so many of these patients are experiencing enough improvement, enough of the time, with these explants that it seems very clear that and maybe there's selection bias of the people who are coming forward for this, but most of them are benefiting from this. So in terms of the biofilm part that you were talking about, there is, we send patients, we give them the choice if they want to send specimens to what's called Microgen DX company in another state. Yeah, and we send Microgen specimens. I typically will take 3 postage stamp size biopsies from the capsule after I've done the capsulectomy of the capsular tissue that surrounds the implant. We take that out with the implant in what we call the en bloc or total intact capsulectomy method whenever we can. And then we open that on the back table outside the body and look at what's on the inside. And we will, if we're sending Microgen, we'll send 3 postage stamp size biopsies. Then we'll also swab the interior surface of the capsule that was touching the implant, and we'll swab the outer surface of the implant that was touching the capsule. And we sent, so those 3 kind of sample swabbed in a jar of 3 biopsies, and we send that for each breast in a kit, FedEx it, and we usually get an answer within a week as to whether anything was recovered. Now, one of my colleagues, Dr. Whitfield, published a series of something like 600 implant Microgen specimens that he sent for the purposes of research and publishing a paper. And about 30%, 29 something percent of those patients had identifiable DNA of microbes, biofilm, recovered. Now, most of the time it was skin flora like Staph epidermidis, Staph aureus, Corynebacterium. Only a small number was at mold. There's a big fear of mold in the explant community, with them thinking that it's the primary culprit here. There's no proof of that. I've certainly seen examples where there is candida that has been able to be recovered mold from the surface. And I've certainly seen implants that look, or there's stuff on the inside of that capsule that looks weird, cheesy, cottage cheesy, dry, chalky, but it doesn't always mean that mold is being recovered or even bacteria are being recovered. Some of that may be that it's a sampling challenge. You could have a crime scene and there might be DNA somewhere in the corner and you thought you swabbed every reasonable nook and cranny to get, see if you can find the culprit, and you never did. Doesn't mean there wasn't a culprit. But we don't have proof today of a specific microorganism to cause BII. One study looking at this did Microgen testing on all their specimens. They also did heavy metal testing and some other tests. And what they found is the explant group that had BII symptoms had high level of arsenic, but a control group of women who were having only breast lifting, who never had implants, also had high arsenic levels. And both groups had a lot of tattoos, and they ascribed maybe that to be a confounding from tattoo levels. And critics of the data that, like in Dr. Whitfield's study, which was published in a microbiology journal, but critics would say, well, what about, if you want to say that biofilm caused it in all of these patients, well, what about the 70% where you didn't identify any biofilm? Is it that you just didn't identify it, but it was present and the cause, or is their BII caused by something else? And so that's part of the challenge here is, we don't have a very compelling, oh, this causes that, and we can say it for certain. But things change in medicine, and the only way they change is if you challenge paradigms and you think about it, which is a good thing that you're doing here, not just in your podcast, but in your practice, challenging some of the paradigms on what is safe and effective. I think it's unreasonable to think that any specific biochemical exposure should be universally accepted by all organisms in the same way. We don't believe that about any food, right? I mean, peanuts, some kids will have peanut allergies where it's life-threatening, and other people are like, what's the big deal? They think peanut allergies is kind of a joke and a hoax. And there is a specific reason why peanut allergies, by the way, as a digression, were a big problem in the US and not in a lot of other countries. And that's because American Academy of Pediatrics for many years was promoting the idea that kids shouldn't be exposed to peanuts until their 3rd birthday, when it turns out that actually to build your immune system and your tolerance to things, there's some things you can't be exposed to too early, but peanuts is not one of them. And if you get exposed to peanuts before your 1st birthday, you're much less likely to develop a peanut allergy. And so much so that is now the recommendation by pediatricians, and the AAP had to retract a 20-year recommendation that has caused a lot of harm. This was published in my friend Dr. Marty McCary's book, and he's now the FDA commissioner. He was just appointed and confirmed as a new FDA commissioner. But one of his best-selling books was called Blind Spots, and one of the vignettes there was about peanut allergies. And this problem that developed because of poor policy that was informed by bad interpretation of scientific data. So, but getting back to the idea of that things change, well, I was taught in medical school that a healthy diet was at least 50% complex carbohydrates. So we would go to school eating a bagel and say, well, at least it's
No.
not, eggs, that I'm having for breakfast because this is fat-free and is, carbohydrate. It turns out that eggs would be much better for me to eat for breakfast than a bagel, which we learned over the ensuing 30 some years. So things change. Peptic ulcer disease, the generation of surgeons that trained me at Mass General and UCSF, they trained in an era where you were doing a lot of radical surgery to treat ulcer disease by cutting the vagus nerve, which stimulates the gut, cutting branches of the vagus nerve, taking up part of the stomach organ that produces acid, with the idea being that you're reducing acid hypersecretion and that will reduce ulceration. And while it can do that, it's a very radical thing and it disrupts a lot of other normal things that the stomach, an acid-base balance and protective mechanism. Then some scientists, a couple of scientists independently theorized that maybe a bacteria caused a lot of this ulcer disease. And one of them swallowed a beaker of H. pylori to prove his point and gave himself severe ulcer disease, almost died. Later, he won the Nobel Prize for discovering the role of H. pylori in peptic ulcer disease. So today, if somebody has H. pylori on a breath test or a biopsy, they can be treated with Pepto-Bismol and a couple of antibiotics for something like 3 weeks and be largely cured of peptic ulcer disease and not have to have part of their stomach removed. So this is taking a surgical disease and turn it into a medical disease.
Mm-hmm.
So will we find the H. pylori in quotes of BII? Maybe. We won't find it if we ignore BII or we think that this is all in the patient's heads and we just sort of stick to the party line of plastic surgery and saying, this is threatening our livelihoods of doing implants. So let's not give any credence to this. And the FDA has to walk a very tight kind of tightrope on this to say, we don't know what is the cause specific. We know there's a phenomenon here. We should warn people about the phenomenon so that they make an informed choice if they choose to accept the risk associated with this phenomenon.
Mm-hmm. Now, you bring up a really good point about not knowing what comes first. When I'm conducting a study myself, it's a independent and it's also kind of volunteer based. So there's some bias in there. People who've experienced what a suspected implant illness of any type, but I am looking at the GI map. So that's the stool analysis, and it does have the H. pylori marker on there. I know that 80% of all of my clients, regardless if they have implant illness or not, or suspected, that is showing up. But specifically what I'm noticing in the GI map of people with implant-related symptoms, I'm seeing that the butyrate producers in the microbiome are what's really, really low. I'm seeing there's a non-detectable Akkermansia, Fecalium bacterium. There was a couple others. I don't have the study in front of me, but there was probably 4 or 5. All of them revolved around the gut lining, like the actual mucosal barrier, the integrity. And so I'm seeing them low, which points to leaky gut. And that's a term that we all hear now. It's pretty popularized. So I'm thinking with that and with the data that you all are collecting in terms of the biofilm bacterial formations, it would be really good to have all of that data pulled together. And so we could do more of a diagnostic, like a questionnaire that would be able to help assess this.
Right. And I think inevitably we'll get there. There's a lot of this basic science on the physiology of the capsules and silicone biomaterial exposures going on in the Netherlands. So I'm on several webinars a year with a group, kind of a work group that includes some BII advocates who are explant patients themselves who've had a lot of health issues that in most of their cases improved a lot after they explanted, and now they're kind of champions, and to some extent they're champions for the idea of either re-engineering what we make breast implants of or just getting rid of them as a category of devices. And again, that's controversial and that puts them in view of a lot of plastic surgeons and other physicians sometimes as, okay, is this a fringe movement or not? And again, that's where I say that the truth is probably somewhere in the middle, which is that there are some people who are, just like I was saying with peanuts. I mean, there are people who can't eat gluten from when they're, children. and they have celiac disease, and you're not going to cure them of this. You just have to modify what they eat, and they're just not going to eat gluten. And then there are people who are like, oh, come on, I've been eating this, kind of gluten-heavy pastas and stuff like that my whole life, never had a problem. And then there are people who, like me, who I could eat whatever I wanted until I was about, late 30s, early 40s. And then, I started to gain weight much more easily. Um, I've lost weight recently, but I've had to go on tirzepatide, GLP-1 meds to regulate my insulin levels and my cravings and stuff. And it's worked very effectively for me. But, you know, but like my metabolism is not the same as it was when I was younger. And our immune systems are programmed in a way genetically and just through repeated mutations, micromutations, and things that happen from exposures, our somatic expression of our genome, which is what our cells are doing with our genes. They get mutated. That's why people get cancer. That's why people get inflammatory illnesses. That's why the skin looks different after a lot of sun exposure as you get older, because you're getting damage and it's causing DNA damage. And melanin, for example, is being expressed when you get a suntan. It's not, I mean, I like the way I look with a suntan as much as the next person, but a suntan is really not a healthy thing because it means the body is getting damaged by ultraviolet energy, and it's protecting itself by increasing melanin, which is a protective molecule. So, the idea that we should expect everybody to just have these devices made of these materials and everyone's going to react the same way, to me is preposterous. Now, when you're managing policy, as Marty is going to have to do as an advocate at the FDA and in running it, and with the new Secretary of Health and Human Services, is a bit of a contrarian, as we know, Secretary Kennedy on a lot of paradigms in health. And there has to be a balance between making recommendations that are very strongly scientifically backed and also looking at real world evidence where you might not know the exact scientific explanation for a phenomenon, but you can't ignore the phenomenon, and you need to kind of figure out how to build policies around that. And but I think that the FDA has a tricky responsibility here, where they can't ban things outright without good data, and at the same time they have to make people aware of risks so that people can be informed. Not just for the legal reasons, but just honestly, ethically and morally, just, people should kind of know when if you choose to smoke, that's your choice. I think it's reasonable to have policies to say you shouldn't be able to smoke on an airplane, which I can't believe people could do. When I was a kid, I remember it's a smoking section on an airplane, an oxygen-filled tube in the sky, and people were allowed to light fire. It just makes no sense, right?
Right.
Yet it was only in the 80s that finally got banned, the late 80s, if I remember. So, uh, uh, when you look at approving and or banning devices, there has to be a preponderance of evidence of a general level of accepted risk. What that level is, it depends, and it kind of depends on your personal theories, but there are sort of societal norms, I guess, and statistical norms. It's like, if you go to a restaurant that has an A grade from the health department in your county, that might mean that they allow 1 part per million of rat hair in food, and it's still okay. And you and I would probably say we want 0 parts per million of rat hair in our food, and yet there are contaminants all around us and inside of us, and our microbiome is ever changing. And so we have to be open-minded about this, I think, and we have to be open to the idea that you're not going to expect every organism exposed to the same exposure to react the same way over time.
Mm-hmm. And we have our biomedical engineers and, the surgeons, everyone who's contributing to the data, trying to develop other materials that might be used. And I'm not sure about with the breast implant world, but I know with the hernia mesh, the gold standard is polypropylene.
Right.
They have hybrid that has still a form of polyester in it. That's what I was implanted with, and that's what caused me, like my disorders came immediately after the surgery. So I knew that was my triggering episode. But that doesn't happen always. So I do like to see that the research has garnered more attention along the lines of safer materials. There are some procedures that are life-saving, as you mentioned, and they do require foreign bodies implanted in the body. So you can't get around that unless you make that life.
Right. And it's possible that some biomaterials are simply just a little bit more inert than others.
Right.
Dacron vascular grafts have been used for decades, and we don't really have a great alternative. I mean, there are allografts of blood vessels you can use for small utilization. Certainly, like if you're doing heart surgery, you can use the patient's own veins and radial artery and their internal mammary arteries to bypass to the heart. But for valves, it's largely either synthetic valves or biologic valves like bovine, cow valves and stuff that are sterilized and removed of certain triggers. There's a whole, the interesting thing is that you wouldn't think of this being a plastic surgery topic necessarily because of what people think plastic surgery is, which is a cosmetic. But the reconstructive surgery is plastic surgery as well, and regenerative medicine is part of that. And in particular, tissue engineering and allotransplantation. There's a lot of overlap. In fact, the first kidney transplant was performed by Dr. Joseph Murray at the Brigham and Women's Hospital in Boston, one of the Harvard teaching hospitals, and he was a plastic surgeon. And he was in fact, I interviewed with Dr. Murray, when I was a resident, and I trained at the sister institution, Mass General, for my general surgery residency. And we're kind of very proud of that legacy that transplant surgery, at least solid organ transplants, really kind of started with plastic surgery because of the plasticity of the human body is where the term comes from. It's the same Greek word plastikos. It's not because we use plastic materials. People think breast implants, they think it's something plastic. But no, it's the plasticity of the body and the fact that you can model, mold, and shape the body. And transplantation science is related to that. So the science of tolerance, of what it means to make your body tolerate an exposure to something that is not of itself, that is not its own DNA. If you have an organ transplanted, there has to be enough of a DNA match, which is why you have to find the right kind of donors who match on enough of the haplotypes of enough of the antigen triggers that you can accept it with a reasonable amount of suppressing of your immune system's reactivity to the foreign object, and can live with that organ hopefully for the rest of your life. And still, some people will get an organ transplant and some will reject it even though it's supposed to be matched, and they'll reject it early, and other people will reject it over 20 years, but at least they got 20 years out of that kidney. So in the case of foreign materials, they do present antigens, and this idea of inertness, well, maybe some are more inert in some people than in others. And maybe it's not really inert, but it's at such a low level of trigger that most people can suppress, or their immune system and inflammatory cascades are such that this is not enough to like raise the siren,
And then the reaction rates of these materials is a whole nother topic, like depending on the temperature of the body and so many other variables. But just to bring it back into the breast implant community, what post-operative care would you provide them or support them with for the best possible outcomes, really?
So there are a couple of things. The first is, I think, in consulting with them ahead of time, you have to be honest with people on expectations aesthetically. You have to have two parts of the conversation: the functional goals and what is often seen. And I separate the functional goals, by the way, into the BII sort of symptomatology that I think is a biochemical immune system related issue from physics. So the physics of having these objects typically under the muscle, in most cases in the US, and sitting on your rib cage, there's an anatomic physical aspects, like the fable of the nursery rhyme, or the fable of the princess and the pea. And they knew she was a princess because she could detect a pea under a mattress, 100 mattresses below her. We have these objects that are between your rib cage and your muscle. When you take a deep breath, the rib cage expands, the muscle pushes back against it, and you get this shock absorber that's being squeezed. And if it's stiff because the capsule is thick, or it's a saline implant that is stiffer than a silicone implant, you may feel shortness of breath. And that's not BII, that's physics. And that you can tell people with pretty much certainty that's going to get better because the object won't be there anymore. When they say that my neck and shoulders are killing me, and I can't find a good fitting bra because of all this extra weight. Well, that's weight, that's physics again. And I don't mean to minimize it. I'm just saying it's a separate aspect that we can say is specifically due to the implants, because it's due to the weight of the objects and their physical presence and the disruption of normal chest wall anatomy. In terms of preparing patients, so we talk about the physics, we talk about the BII symptomatology, we talk about the knowns and the unknowns that we've talked about here on the podcast. In terms of setting the expectations, the leap of faith aspect of that, we spend a good amount of time on the aesthetic expectations, which are determined 90% by the patient's anatomy what they have for breast soft tissue, what cup size they naturally are or were. Have they had children, breastfed, gained or lost a lot of weight? Where is the breast sitting, the nipple sitting? So those inform things like, should we do a lift to reduce the skin to match the volume? Should we consider fat transfer to augment you back part way so you have less of a sense of loss of some of that volume, or to mitigate some of the concavities and things that can happen? In terms of aftercare, there's the initial post-op care, which is to reduce the risk of immediate post-op complications that could require going back to surgery, like restricting activities so you don't cause bleeding or pull on your stitches, the potentially responsible, use of drains temporarily for a week or so, which a lot of us do to minimize fluid buildup, help the tissues to heal. And then there's a whole other aspect of this, which is supporting gut health, supporting, encouraging patients for, better sleep patterns, vitamin C, protein intake, magnesium, iron if they are iron deficient potentially, glutathione, supporting their methylation pathways properly. There are a lot of supplements and things like that functional medicine specialists know better than I do, but we try to incorporate that into a dialogue with the patients, and we often will refer our patients to outside functional medicine. We're working on bringing in a system that has been adopted and developed with another colleague, by another colleague, and bringing that system in to offer it to our patients as well, to give a more, longitudinal immune support for the patients. I don't hold myself out to be a functional medicine expert, but I'm also doing a deep dive into learning more about functional medicine. I may end up, taking enough coursework and doing enough to certify myself in functional, as I think that what I've learned from being involved with these patients, they've taught me more than I've taught them, and what I've learned from them, and my own health journey and my own children's health journey, as we look to see what are triggers in our environment and in their food and things that maybe we can do better about, to support brain health and gut health and behavioral growth and all of that. Is that there's more that we don't know than that we do know about this interplay of exposures and our immune systems in our bodies, and that holistic and functional approaches are clearly the vanguard and the way medical science has to go, because you can't just treat illness, you got to support wellness, and you can't just do after the fact retroactive care, you got to try to do proactive care. So to those who say, well, then don't put breast implants in the first place, I think that's fine. If that's the choice a patient wants to make, great. If I never put in the breast implant, I'd be okay with that, because I do so many explants, creating a lot of benefit for patients. But also, there's something that's very getting back to the basics of taking good care of patients and trying to help people's health, that I feel like we're achieving by doing explant surgery. And I'll get back to that thing that I said earlier, as a father, of not to hold my daughter out as a prop or anything, but I think there is something that my industry is unfortunately culpable in, which is this idea of making people feel like they can't be enough as they are, and that we should be afraid or ashamed of our nature. No, we can optimize our nature. We can, otherwise you're not growing, you're not evolving. And I have a podcast of my own, and we talk about this. And we talk about what it means to be optimizing your performance. So we speak about BII, but we also talk about general health and nutrition and challenging medical paradigms, and what it means to be mindful, what it means to try to lower your anxiety, what it means to perform well at your job or in your relationships. And all these things are interdependent, because gut health, brain health, body health, they're all of a piece. They're all of making this organism thrive or not thrive.
Yeah. And I love that you talked about being proactive there. That's what I do with my practice, in that, they've already had the implant, they're working towards an explant. So we pre-tox is the term that we use. We really optimize the body, make sure that those drainage pathways are opened up, make sure that their nutrition is dialed in, and everything is as optimized as can be going into the surgery. And then, of course, the medical team assist them during the recovery process, and then we come back in to help them with the detoxification, the gentle, mild detoxification ongoing, so they can sustain the better health. So I do appreciate that. And you did mention you had a podcast. So how can people learn more about you? How can they reach out to you? What forms of media are available?
So my handle on Instagram and TikTok is at Tim Syed MD. So my practice is Tim Syed, MD, my logo here, and basically, um, uh, and that's what I practice as Tim Syed. My full name is Hatem Abu Syed, but it's a little bit hard for people to pronounce. So I got a nickname of Tim when I was 5, so people could say my name in a way that wouldn't bother me as a kid, and that wouldn't feel teased, and that stuck. So, and then my podcast is called The Scalpel's Edge, and we talk about being on like the bleeding edge of performance, which we're all striving for, I think, ultimately. And so to me, it speaks to, yes, I'm a surgeon, so, I use a scalpel in my work, but it's the idea of being on the leading edge, the bleeding edge, the scalpel's edge of performance, and what that means in terms of all the factors that play into that. And I'd love to have you on reciprocally as a guest. If you're open to doing that, you don't have to answer me on your podcast today. And we're looking to we have a lymphatic massage therapist that we refer a lot of our patients to. She's going to be our guest pretty soon. Trying to bring in other key opinion leaders, KOLs out there in wellness, to talk about this. And I think you're seeing a lot of influencers in this wellness space who came from traditional medicine or from surgical specialties, and are either because of their own personal experiences with their own health or family members or with their patient populations have said, there's a lot here to uncover and to learn from, and we need to kind of dialogue on it.
Yeah, so I appreciate all of that. We'll make sure to include your resources in the show notes. And Dr. Syed, thank you so much for joining us today on the Functionally Enlightened.
Thank you very much for having me. I really appreciate it. Keep up the good work.
All right, and thank you to all of our listeners. We'll see you on the next one.
Bye-bye.